Okay. Do you want me to get started, Dr. Danzer?
Sure.
Okay. Well, thank you all for joining us on our webinar today. We'll be discussing understanding infertility and common misconceptions and hope after diagnosis. I'm joined today by Dr. Hal Danzer, one of the founders of our practice. Okay, next slide. I'm Dr. Susan Maxwell. I work in our Santa Barbara location. I am board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. I completed my training in OBGYN and a fellowship in reproductive endocrinology and infertility at New York University School of Medicine. I've had extensive training and experience working at top fertility programs in New York prior to moving to Santa Barbara, and I'm happy to be a member of Southern California Reproductive Center. Next slide.
And we're happy to have you.
Thank you.
Very happy to have you.
I'm joined today by Hal Danzer. He is one of the founding partners at SCRC. He has helped numerous patients over the years fulfill their dreams of becoming parents. He is also board certified and a member in the Department of Reproductive Endocrinology at Cedars-Sinai Medical Center. You know, we enjoy working together. Hal Danzer is in our office in our Beverly Hills practice.
I always like to tell the story about my grandmother, who was a midwife in rural Montana in the late 1800s, early 1900s, and try to compare, what she had for women's care or fertility enhancement. Of course, back then, everybody was getting pregnant when they were 18, so there wasn't a lot of infertility, but as opposed to what we have today, where when we transfer embryos, I look at the screen and see that one little embryo that we transfer, and pregnancy rates, 70% plus. And what's really happened in just really 2 generations in the science of helping people have their families. I'm happy to be part of that.
Well, here at SCRC, we're very proud that we have a proven track record and more than 25 years of experience in the industry. We have 2 state-of-the-art embryology laboratories, one in our Beverly Hills location and one in Santa Barbara. Both locations have on-site surgery centers. And we also have monitoring centers in Pasadena as well as Ventura.
We've had probably the largest experience with egg freeze in Southern California and embryo transfer in the Southern California area. So we've been here for a while and really been very successful in helping people have the optimal chance of having their families.
One reason we've had so many success stories is our premier embryology laboratories. We have experienced and certified laboratory directors. We've been doing double witnessing verification in our labs so that we make sure that we are transferring the correct embryos. We utilize vitrification for our freezing our gametes, and this is a flash freezing technique which improves survival rates and outcomes. We also do a lot of blastocyst biopsy, testing embryos for genetic abnormalities, either chromosomal abnormalities with PGT-A or single gene disorders for our PGT-M cases. And we have a lot of experience and successful outcomes with this technique. We are also fortunate to have embryoscopes available in both of our laboratories, and these are time-lapse video analysis devices for embryos. Embryos are cultured in the embryoscopes, and we get images of their development all along the way. Next slide. So today we'll be talking about infertility. It is National Infertility Awareness Week. And so we hope that you'll be able to understand a little bit more about infertility and why it happens, what are common misconceptions, and the treatments and testing that patients undergo at our center. We'll share some stories of patient success, and then you'll be able to do a question answer session after. Okay, Dr. Danzer is going to start the presentation.
Thank you.
Mhm.
So it's National Infertility Awareness Week, and if you look, it's 1 in 6 couples have difficulty with achieving pregnancy, and certainly that's a greater proportion than back when my grandmother was helping people with their fertility. People were getting pregnant when they were 18 and 20 years of age, and genetically their embryos were just healthier and better. Age has been the biggest determinant of our ability to help couples get pregnant. On average, each one of us is 1 out of 3 or 4 embryos from our parent. The first 3 embryos didn't make it because they weren't genetically good, and that's very much age related. And why fertility or infertility issues have been increasing in the past 20 years because couples are delaying getting pregnant for education and careers and a variety of other things. And the genetics of the eggs tend to be the culprit, unfortunately. And the definition of infertility for women under age 35, if you're trying to conceive for a year and been unsuccessful, but if the woman is over 35, 6 months really is an indicator that it's time to at least do an evaluation and determine a path forward in terms of optimizing the couple's fertility. So individuals can experience infertility as a profound emotional loss. It's one of the most difficult things that any women or a couple have to undergo because family is the greatest piece of our life in many, many ways. And it's important to be open to the fact that recognize that grief and anxiety and shame are part of what is experienced by the man and the woman or a single woman. Um, Again, everybody expects that they ought to be able to get pregnant easily, and there's not a lot of awareness that infertility is so common today. Patients often kind of internalize their blame. They're unaware of the biologic factors beyond their control. And this emotional burden can be alleviated through compassion and communication and evidence-based treatment on the age factor. So it's important to understand that there's a psychological or emotional component to infertility. Uh, Unfortunately, there's a lot of friends and family that don't recognize this, and that they tend to blame the woman, and many times it could be the man or a combination. Um, but it's important that couples or individuals going through the infertility evaluation and treatment, that they really understand that there's a lot of underlying issues that come to the surface at different times. And it's important to be able to recognize that and be able to, talk to someone, hopefully someone at our clinic or their partner, to understand the process. So next slide. So we're going to talk about the common misconceptions. Maybe we'll trade on off about this. So maybe you could start off and do the first one, and I'll do the second one.
So one misconception is that infertility is typically the woman's fault. So I don't like how that's phrased in terms of infertility is nobody's fault. It is a biologic condition, as Dr. Danzer stated. And actually 1/3 of infertility is attributed to the female partner, whether that's due to declines in egg quality or any uterine or tubal factors. 1/3 is attributed to the male partner, which could have to do with hormone imbalances or issues with sperm production or motility. And 1/3 is a combination of problems in both partners. Or in a lot of cases, when we do a workup, everything could be normal, and it's what we call unexplained infertility, and that happens in about 30% of couples. So nobody should feel that they're individually at fault for infertility occurring. Mhm. Mhm. Another misconception is that infertility can't occur in young individuals, and this is not true. We see a wide range of individuals, ranging from women in their mid-20s all the way into their mid-40s. And there can be different causes at different ages, but it can impact anyone at any time. There are different conditions that contribute to infertility, such as polycystic ovarian syndrome, or endometriosis, fibroid uterus, premature ovarian insufficiency, or recurrent pregnancy loss. Mhm.
Yeah, they estimate that 15% of women may have some degree of polycystic ovary where they don't ovulate well or not at all. And that can occur late teenage years, early 20s.
Mhm.
Uncommon.
Mhm.
And then male fertility does not decline with age. Well, everything declines with age. There's certainly there's studies to indicate that men over 45, their offspring have a higher incidence of autism. So there are some genetic issues. Certainly, sperm counts and motility may decrease with age. But sperm are made every day, so they don't have the issues where the woman who was born with the eggs she has and that age effect to the mid and late 30s can affect the genetics of the egg. It's less a factor for men, but it's not absent. One of the things we do when we treat infertility couples that are stimulating with fertility medications, we often do IUI, intrauterine insemination, where they select out the best swimming sperm and put that little drop of fluid in the uterus. And studies are numerous that show that even men with great sperm counts, uh, filtering out the best sperm do help to improve pregnancy rates. Next slide.
Another misconception is you just need to relax more to get pregnant. Um, well, stress I find in my patients is often multifactorial. So while too much stress can affect all different aspects of your health, reducing stress alone doesn't necessarily guarantee pregnancy. But I do see patients that have numerous stress factors in their life, whether that's emotional stress, physical stress, such as, exercising, frequently, nutritional stress, work stress, multiple stressors can impact how how your treatments are going, or sometimes ability to get pregnant. So I think finding ways to reduce stress can be beneficial. Mhm. Mhm.
Yeah, certainly stress reduction um, has been shown in multiple studies to affect how quickly a patient responds to a treatment, and not just infertility, but high blood pressure and diabetes. And stress is not good for your immune system, and it affects uh, many different physiologic parameters within the body. The trick is how do you deal with stress? And stress management, I think, is a very important thing when you're going through fertility treatment. So, so another myth, birth control use can extend is for an extended period as a cause of infertility. And the studies don't show that. Actually, women that are on birth control pills, particularly over a long period of time, reduce the number of times they have stress, and or the incidence of cyst on the ovary is less. So it may suppress endometriosis. So there's birth control pills particularly do not cause any issue with one's fertility.
The misconception, infertility is rare. As we've discussed, it's actually very common. 1 in 6 people of reproductive age are impacted by infertility globally. So it is a very frequent diagnosis. Next slide.
So we can start, we talk about the natural ovarian aging process, and you can see with the at birth, this image of the ovary, and you can see all those little small circles are what they call follicles, and there's a microscopic egg inside of each follicle. Generally, women are born with millions, so by the time they're teenagers, you're down to maybe 50,000. We don't know why most of the eggs have released during that period of time, but that results in what they call menopause at on average, age 50, where all the eggs have been released. So that's what creates the problem with fertility in the late 30s or mid 30s and beyond, is the decreased numbers of eggs. And as the egg reserve diminishes, the proportion of eggs that are genetically healthy declines also. Next slide. So again, these are slides look at the age and fertility, and also the percent that are genetically normal eggs. And you can see both of those trend down starting in the mid 30s and beyond. Next slide. Susan, maybe you can take the patient evaluation part.
Yeah. So when we see a new patient in our office, we take a detailed medical history, and we get to know you and get to know your unique situation. We do a physical exam and diagnostic testing. Okay, next slide. So some of the tests that we do is we do some ovarian reserve testing, and this is to get a sense of the number of eggs in the ovaries. We can do this either through blood work. So we test a test called an AMH, which is anti-Müllerian hormone, and that's a marker of the total number of eggs in the ovaries. Now, a normal AMH is 1 or higher, and the AMH levels do decline with age. We also look at FSH, which is follicle stimulating hormone, and this is a hormone that will go up as the egg pools decline in the ovary. And then we do a vaginal ultrasound, and when we look at the ovaries, we look for resting follicles, which are the little black circles here within the ovary. And that gives us a sense of how healthy the ovaries are, how many eggs there are available to stimulate. Next slide. We also do different types of tests on the uterus. And these images are of a test called a hysterosonogram. And with this test, we put a thin catheter through the cervix into the uterus, and we put some fluid, some saline fluid inside, and we do an ultrasound, and we're able to see the walls of the inside of the cavity and make sure that there's nothing inside the uterus that could be impacting fertility. For example, here in the second image, we see some tissue inside, and this is a uterine polyp. So when we do find things inside the uterus, then we can plan simple procedures to remove them. Next slide. This is another test which Dr. Danzer is specialized at performing. Do you want to talk about these?
Yeah, hysterosalpingogram is a way of imaging the uterus, the shape and its volume. Again, looking for fibroids or polyps, which can occur inside the uterine cavity. And you can see there in the center, it has a little triangular shape. And then we watch the contrast material flow out the fallopian tube and then spill out into the pelvic cavity to tell us that the tube is open. Obviously, a blocked tube could prevent pregnancy. But this is a routine test and it's relatively easy to do. But again, it's a way of analyzing if there's any anatomical issues creating fertility problems. So male testing, if you look to the right, they say normal, and then all those abnormal forms, there's only about 15% they're normal or 20% for most men. Again, sperm production is millions are being produced day to day, and Mother Nature just doesn't get it right a lot of the time. But again, if we look for a concentration of 20 million sperm per cc or ml, and we look for motility, which is about half of the sperm would be swimming. And that's probably the most important factor in the analysis is that the sperm swim well. You'd have to have a very motile, high-speed swimming sperm to be able to find the egg and also to burrow through the outer coating of the egg to fertilize it. And then we also look at the shape of the sperm, but as you see on the right, probably 80% are abnormal shaped. It's only the fast swimming sperm that are able to find the egg and fertilize it. Next slide. There we go. Holistic approach.
Holistic approach. Next slide, please. So, we believe in a holistic approach when treating our patients with infertility. And again, this goes back to helping your whole self, mind, body, and reducing stress. So some treatments that can be effective are acupuncture, mindfulness techniques, sometimes going to therapy or support groups can help reduce stress associated with infertility. And then nutrition is an important factor as well. Next slide. Vitamins and nutrients are linked to positive effects on fertility, and healthy diets such as the Mediterranean diet, which includes plant-based foods such as whole grains, vegetables, legumes, fish, nuts, and seeds, provide important nutrients that are beneficial for fertility. And specific vitamins such as folic acid are important to support early normal fetal development. And folic acid is present in legumes, asparagus, or dark leafy greens. In women who are taking a prenatal vitamin, this should include folic acid, and we recommend that you check to make sure that your vitamin has at least 800 micrograms per day of folic acid. Vitamin B12 is another important nutrient. It's available in organ meats, such as liver, kidney, beef, tuna, fish, and omega-3 fatty acids. Overall, when you're thinking about healthy nutrition, it's important to reduce processed foods and focus on whole foods and foods that you prepare yourself. Next slide. Acupuncture can be a helpful additive treatment to fertility. It can help improve sleep, reduce stress or modulate the nervous system, and improve blood flow to the uterus and ovaries. And it potentially can help with relieving stress and balancing hormone levels. Next slide. Again, managing stress, while stress does not directly cause infertility, multiple stressors on top of each other can really impact your hormones and your regulation of your periods, ovulation, and your effect, how you respond to fertility treatments. Prolonged stress produces hormones such as cortisol and prolactin, which may interfere with normal ovulation. And meditation, moderate exercise, getting enough sleep, eating a healthy diet can also help to manage stress. Next slide. Next slide. So in terms of fertility treatment, we offer all fertility services here at Southern California Reproductive Center, including assistive reproductive technologies such as in vitro fertilization. We do frozen embryo transfers. We do pre-implantation genetic testing of embryos, which is embryo biopsy. We do, some of our patients are getting sperm retrievals, meaning testicular biopsies to retrieve sperm. We perform techniques such as intracytoplasmic sperm injection to help with male factor infertility and assist with fertilization of eggs. We have a donor sperm program for patients who are using donor sperm. We can help screen donors as well as screening of egg donors. Other fertility treatments, we treat polycystic ovarian syndrome. And we do intrauterine insemination cycles. Next slide. Patients who are undergoing intrauterine insemination, usually for these type of cycles, patients will take an oral ovulation induction agent such as Clomid or Letrozole to help with ovulation, or sometimes help more than one egg to be released from the ovaries. We then do ultrasounds throughout the cycle to see how the follicles are developing. And when there is a dominant follicle that is the right size, we trigger ovulation with an injection. And then 24 to 36 hours later, we would perform the intrauterine insemination procedure. Next slide. For patients undergoing in vitro fertilization, this is about a 2-week process. Patients take injections every day for 10 to 12 days to cause multiple eggs to develop on the ovaries. And then about 2 weeks into the treatment, patients are ready for their procedure to take the eggs out. The eggs are fertilized the day of the procedure, and then embryos are cultured in the laboratory for 5 to 6 days, and then typically biopsied and frozen for genetic testing. Next slide. The egg retrieval is about a 15-minute procedure. It's done under anesthesia, so patients get medication so they do not feel anything. We do a vaginal ultrasound with a needle attached, and the needle goes through the vaginal wall into the ovary, and then we suction out the eggs that have developed. Next slide. This is a time-lapse imaging of the development of an embryo. And you can see the embryo starts out at 2 cells and then divides to 4 cells and then 8 cells. And then a morula stage is a compacted embryo, and now it expands into what's called a blastocyst, which is a day 5 embryo.
That's
Next
pretty
slide.
amazing. That's what Dr. Maxwell looked like a few years ago.
Yes. No.
We all did.
It's pretty amazing that that clump of cells develops into a fetus.
Person. Yeah, it's a
Yeah,
person.
into a person, ultimately. So this video here is showing an embryo that is being biopsied. So when we do embryo biopsies, we take around 5 cells from the outer layer of the embryo. This layer forms the placenta in the future. And this biopsy that's taken off is then sent to a genetics laboratory for chromosomal analysis. Next slide. So in patients undergoing fertility treatment, it's helpful to have a support network, whether that's friends or family, therapy, support groups. Um, our staff provides a lot of support, whether that's our medical assistants and our nurses and physicians, um, guiding you through that journey. Again, because this can be emotional, a lot of ups and downs, it is good to have people that you can talk to while you're going through your treatment.
And it's important to understand that everyone has their own doctor. We don't have a doctor of the day. So you have that one physician that is going to review your test each time you have them. And it's important to have that kind of connection and continuity of care for support for the doctor. It's important for the patient.
Mhm. Yeah. Um, and you can be assured that we have the latest state-of-the-art technology. And so we're able to offer you the best treatments available. Really, and again, under that personalized care, your personalized treatment team run by your physician. Mhm. Next slide. Mhm. Next slide. So we have various promotions that happen throughout the year, and you can visit our website to see our latest promotions. We have some promotions going for National Infertility Awareness. Mhm. Next slide. And this is just our team here. We have Dr. Suri, Dr. Danzer, Dr. Alexander are in our Beverly Hills office. Myself, Dr. Maxwell, I'm in Santa Barbara and Ventura. And we have a nurse practitioner, Miriam, who's in Pasadena and Beverly Hills. And so if you're interested in having a consultation or any of our treatments, you can schedule with any of our physicians. And if you heard about us through the webinar, we have promotional codes for when you schedule. And now we'll open up for question and answer.
It's important. I think there's those in the audience that are probably beginning to think about their fertility. They may have been struggling or maybe just beginning to think about a family. Having a consultation really takes a lot of the stress out of for many couples. If they've been trying for 6 months or 3 months or 3 years, at least to get a program on how to go forward. We talk about reducing stress. We have patients that come by and have a consultation, and we're going to start the next cycle, and they call up and say, gee, I missed my period. And it's reduces the stress. Getting a plan can have a tremendous benefit when entering into the treatment. And initial consultation is, we'd be happy to do that.
Okay. So I'm just opening up the chat here as part of our question and answer. So the first question is there a way to do a consultation and get testing done if you live outside of California? So all of our physicians do have telehealth consultations available. So we can speak to you with an audiovisual platform. And then initial testing is oftentimes blood work, and this can be performed at any laboratory in the United States. And then at some point, we would have you come to our office in California for a ultrasound examination.
And some people have ultrasound with a fertility clinic in their area, if that's part of the initial evaluation and the blood work. And then again, the results can be reviewed with telehealth. We do that quite frequently.
If you have any questions, feel free to put them in the, type them into the question and answer. Mhm.
I had a question from a patient today that was using a topical antifungal agent, and she was getting ready to do an IVF cycle. And again, uh, many people are on medications, psychotropic drugs for stress and anxiety. They seem to be very safe when doing an IVF cycle. I think most other chemicals we try to avoid, uh, but never be frightened if you're taking Prozac or one of the other agents. I think there's good evidence that those do not affect egg or embryo quality.
Mhm.
And again, many times patients are taking these meds because of anxiety issues, and some of that is going to be aggravated during the fertility treatments, and being able to adjust the dosage of those with their prescribing physician can be very helpful uh, in getting through the process, which is stressful for some.
Um, So this is a question that says, at what numbers and points do you recommend alternative options like adoption, given the age and biological factors? So when we assess a patient, we look at both partners. We look at the female patient and her egg reserve, if there are eggs available for fertility treatments. We also look at male partners to see if the sperm quality, if we have sperm available for treatments. Some patients use donor eggs or donor sperm if we do not have sufficient eggs or sperm for the patient. Some patients use donor embryos. And some patients consider adoption. So it's really dependent upon the testing results and when we discuss treatments like that. Mhm. Mhm.
We had a patient recently who luckily had frozen her eggs about 7 years before, because when she came in for evaluation, late 30s, I think she was 39, and her cycles were irregular. And we did the testing for her egg reserve. It was very diminished, and her FSH was elevated, her AMH was very low. And those kind of tests indicate that she'd have a much better chance of being successful using the frozen eggs. And we didn't talk about freezing eggs today, but that certainly can impact the potential for having a family in the future.
Mhm. Here we have a question of a patient turning 43. Is she still a candidate for fertility testing? And the answer is yes. You're still a candidate for fertility testing and potentially treatment at 43, depending on those results. Mhm. Okay, well, I don't see any other questions. Do you have any final thoughts, Dr. Danzer?
I think, as I mentioned before, I think in the audience are couples that are for individuals that are thinking about their future fertility, consultation can be helpful. Again, to decrease the stress, but to get a plan, how to go forward. And I've seen patients that were uh, came in 3 or 4 years later when their fertility was less, their egg reserve had diminished, and uh, so to come in and have an evaluation, get a plan to go forward, looking at the uh, kind of test results we can give now to say, gee, you've got a great reserve, and if you're not planning on having your family now, that in 3 to 5 years, your fertility should still be good if you're in the mid 30s. Um, so it's having a plan to go forward is always helpful, and we're more than happy to help you get that plan.
Yeah. And we see a lot of patients too who are maybe just thinking about starting a family, and they want to, they may be starting a little bit later in life, and they just want to come in and get checked out, check their fertility, and make sure that they're maximizing their chances really from the start. And so we're happy to also help with that and provide those evaluations. Mhm. Okay, well, thank you for joining us today. Mhm.
Happy Fertility Awareness Week.
Okay.
We'd be very happy to work with you in the future if you feel that that's a good thing for you.
Mhm.
Have a good evening now.